So this is going to continue to discuss the role of disease prevention and the role that physical activity and exercise can play. And then towards the end of this lecture, we're going to move into a review of the physiological responses to exercise, so we all kind of know what to expect when somebody exercises. So continuing on with physical activity and its role in preventing disease, all of this information comes from what we call epidemiological studies. So these studies look at the incidence, distribution, and control of a disease. And so in the context of exercise and physical activity, these studies are usually long-term, like at least a few years, and they look at physical activity in a group, usually referred to as a cohort, and then they follow them up and see if whether or not they got certain diseases, and then if those diseases are actually statistically linked to the amount of physical activity that they were doing. So if you look at the research that's out there, there's an overwhelming amount of information that physical activity is beneficial for health, as you could imagine. So some of the key diseases that could be impacted or prevented by engaged in more physical activity include things like coronary artery disease. The risk of a stroke is always minimized by physical activity, reduction in blood pressure, so reduced chances of becoming hypertensive. Type 2 diabetes can be prevented via physical activity. Certain types of cancers, namely breast cancer and colon cancer, can be prevented by engaging in physical activity. And then there's some other things where the evidence is not quite as strong, but there's definitely some links out there like dementia, and it continues to go on, and they're finding new stuff every so often as far as gathering information on what's useful or not in preventing these diseases in the context of physical activity. Another one that I wanted to point out at the top is all-cause mortality. So just the risk of death, there's a really significant relationship between how much physical activity and exercise you do and risk of just death from any cause. And so that's a pretty statistically significant relationship as well. So to look at some of these, I just put up a few landmark studies that you may have heard of some of these. If not, these are good terms just to know, especially if you plan on going into a field where this might come up. Or if you go to graduate school or anything like that, you might revisit some of these studies. But these are studies that were done, a lot of these a long time ago. First one I put up there, London bus driver study, was actually done in the 50s in London. There was a link between bus drivers and conductors on the bus. The conductors were more active and they had a lower risk of having a heart attack. So that was one of the first epidemiological studies that clearly showed a link between how much occupational activity you're doing that's physical and the risk of having a heart attack. Harvard alumni, Framingham, San Francisco longshoremen, these are all long-term epidemiological studies that were done in the 80s, and they looked at thousands and thousands of people, and they just monitored over these years how much physical activity they were doing, and then looked at their incidence of disease. And what they found was that there's a clear link, and I'll show you some of these data in the upcoming slides. And the last one I have up here is Aerobic Center longitudinal study. This is not just one study, it's an ongoing series of studies that are going on at the Cooper Clinic in Dallas, Texas. And in these studies, they tend to look more at aerobic fitness. So what they'll do is assess VO2 max or aerobic capacity and look at the relationship between VO2 max and the risk of disease. And I'll show you some of that data as we move through this. So this is actually one from the Aerobic Center, the longitudinal study done in Dallas. And this one, again, looked at fitness level, assessed via VO2 max. And so basically, as you can see here, the mortality risk is relatively high in those with a low fitness level. So that means if you're low VO2 max, your aerobic fitness is low. The risk of mortality or death is actually really high. If you can get to that moderate level of fitness, though, or better yet, even the higher level of fitness, meaning you have a better aerobic capacity, your VO2 max is higher, the risk significantly comes down. And the thing that stands out about this graph right here and this relationship is that the biggest drop is when you go from a low fit status to a moderate fit status. So the take-home message from this is that you don't necessarily have to have a really, really high VO2 max. You just have to be kind of average. So as long as you're not really, really low, you're getting a lot of the health benefits. So you can stress this to clients and whoever that you don't necessarily have to have a really, really high VO2 max to get many of the health benefits associated with exercise. This is just some data from one of the Harvard alumni cohorts, and this actually looked at not fitness but physical activity. So you can see the assessment was done in kcals per week of energy expenditure. So these are usually done via physical activity questionnaires. So you're kind of hoping that they tell the truth in what they've done. But you can see when you look at this that the normal recommendation is to do about 2,000 kcals of energy expenditure per week in physical activity. And so that would be about in this area right here. And so you can see the risk of coronary artery disease goes down the more physical activity you do throughout the week. So if you're doing less than 1,000, then the risk is actually pretty high. I mean, these people would be considered inactive. And these people in this group right here, they're somewhat active but not reaching that 2,000 mark, 2,000 kcals a week. And so the risk drops, but then you can see as you do more and more, the risk even drops. So if you can get 3,000, 4,000, you get even more benefit. So this is reinforces that concept we talked about called dose response, the dose response of physical activity and how it impacts health. So the more physical activity you're doing in this case, the more health benefits you're going to receive. And then here's another one. This one's a little different. This is also done off a Harvard alumni cohort, but it specifically looked at stroke. Stroke is interesting because stroke is a cardiovascular disease that affects the brain. But a lot of times in stroke research, they do see this relationship. So this is actually called a U-shaped relationship. So you can see as you go from low activity to higher activity, the risk of a stroke actually drops. However, at extreme levels of high activity, once you get to the upper end, the risk kind of comes back a little bit. So this is called a U-shaped relationship because it looks like the letter U. And why this happens, nobody's exactly sure, and it's not seen 100% of the time, but there are at least 5 or 6 major stroke epidemiological studies that have shown this relationship. So it could be that one of the speculations is that people doing excessive amounts of physical activity also have other stuff going on that could increase their chances of having a stroke. And then this one specifically looks at diabetes. This is one of my favorite studies to look at because this study clearly shows that exercise and diet are actually better than drugs at preventing diabetes. So if you look at this data, and I'll just run through it really quick, they had a little over 3,000 men and women. These were individuals with impaired glucose tolerance, which means that they weren't diabetic, but they were close to being diabetic. That generally means they have a fasting blood glucose between like 100 and 125, somewhere in there. So they're at risk of becoming diabetic, but they're not full-blown diabetics yet. And then they divided these individuals into 3 groups. So one group they gave a diet and exercise intervention to. The second group, they gave them a drug, which is metformin. You may have heard of it, probably the most common diabetic drug that's given. Then they had a control group. So the exercise program was pretty basic. They didn't give a lot of information about it, but it got the people to do about 150 minutes of moderate intensity exercise per week. So that's pretty standard in what the recommendations are. So after 3 years, what they found was that they were in the group that engaged in the dietary and exercise intervention, they had a 58% risk reduction versus the control group. So versus the control, they actually reduced their risk by 58%, which is a lot. And then the group that took the drug, which we all know these drugs work, that's why they make them and sell them, they only had a 31% risk reduction versus the control group. So you can see clearly here they're showing that diet and exercise are better than any drug that treats diabetes. So this is something I like to always bring up when you talk about exercise and health and how useful exercise can be at preventing certain diseases, especially diabetes. As far as cancers, like I mentioned earlier, the major cancers that physical activity has been shown to prevent are colon cancer and breast cancer. So I'm just going to show you 2 slides on that. So these are just different types of studies, cohort versus case control, not a big deal. These are just different types of studies. But the way to look at this, if the little dot falls on the 1 line, that means there's no relationship between physical activity and colon cancer. If it's above 1, that means that the more physical activity, the higher risk of cancer. That would be bad. And then if it's below 1, that means that the more physical activity you do, the lower the risk of colon cancer. So you can see that most, I'm going to say 90 something percent of these dots are below the 1, and all these dots represent an individual study that has been done. So all of these studies that are below the 1 have shown that physical activity is effective at preventing colon cancer. So there's some obviously that show the opposite thing, but they're very few. And who knows why that happened? I mean, I have no idea. But so when you look at this, there's a pretty overwhelming amount of evidence that physical activity can prevent colon cancer. When you look at breast cancer, similar concept, but you can see it's not as strong. Again, most of the dots are below the 1, but there are more above the 1s, which says that some studies are actually showing the opposite. But again, if you take the big picture and look at all of the studies together, you can see that there's clearly a relationship between physical activity and reduction in breast cancer. All right, so shifting gears a little bit, just moving forward in this class, we're going to be doing a lot with exercise testing, so we should review how the body responds to a normal bout of exercise. I just wanted to quickly review this. This is stuff you learned in exercise physiology. But aerobic exercise, like running on a treadmill, if you look at incremental exercise, that means exercise where the intensity gets higher and higher and higher, like a graded exercise test. You can look at how these physiological variables respond. You can see heart rate, obviously, we know goes up with exercise. You can see it here. The clear thing that I want you to notice is that it's nice and linear. So straight line. The harder you're working, the higher your heart rate goes. And we call that a linear or straight line response. And resting heart rate, I put 60 to 80. Somewhere in there is usually considered normal. 50s are generally fine. Max, you can still estimate it by 220 minus age if you don't know your max heart rate. So straight line, this is why heart rate is such a great indicator of exercise intensity, because we know that there's that clear relationship. Stroke volume, in most cases, is going to go up at about 50%, 40 to 50% of your capacity. It's going to level off a little bit. And I put some numbers here which aren't overly important. Cardiac output is determined by heart rate and stroke volume. So hopefully you remember that cardiac output is heart rate times stroke volume. It's the amount of blood coming out of the heart each minute. And you can see that it's just a combination of stroke volume and heart rate. So if you kind of put these two together, you get this. And so cardiac output goes up linearly, and then it still goes up, but it kind of slows its increase a little bit due to the plateau of stroke volume. All right, systolic blood pressure goes up linearly with intensity, just like heart rate did. Diastolic blood pressure during aerobic exercise should stay about the same. All right, main reason is you get a lot of vasodilation. And that ties into this next one, total peripheral resistance, which is the resistance to blood flow, mainly determined by how dilated the vessels are. So during aerobic exercise, your blood vessels dilate, and that's going to reduce the resistance. So you can see that during aerobic exercise, as intensity goes up, there's a nice curvy linear drop in total peripheral resistance. AVO2 difference, which hopefully you remember, is just the difference in arterial and venous oxygen content. So if it was this much at rest and during maximal exercise, it's going to get greater. All that means is that your body is extracting more oxygen out of the blood. So there's a bigger difference between the systemic arteries and their oxygen and the systemic veins and their oxygen level. Blood volume, acutely during an exercise bout, will generally drop a little bit. Some of that's due to sweating if there's a lot of fluid loss, but also just due to pressure. You get what's called a hemoconcentration effect, where some of the plasma is actually pushed out of the blood vessels into the tissues around it. So temporarily after exercise, there may be a slight drop in blood volume, even if you're not sweating a lot. and then generally your lymphatic system will help put that fluid back into the blood. RPP, which stands for rate pressure product. We'll talk a little bit more about this throughout the semester, but it's basically heart rate times your systolic blood pressure. So both of those go up linearly, and so rate pressure product is going to go up pretty high, and it should be in a linear fashion. Harder you work, the higher it's going to go up. So the units would be, they didn't put units here, but beats per minute times millimeters mercury. So it's heart rate times systolic blood pressure. Why do we measure RPP? It's just a good indicator of how hard the heart is working. And then this is a pretty basic slide. Blood redistribution. So this is blood distribution at rest. So you can see it's kind of going all over the body. You get some to the kidneys, the liver, muscles, brain, everywhere else. During exercise, the biggest thing you see is more blood going to the active skeletal muscle. So there's a redistribution of blood flow going to active skeletal muscle. And then you maintain blood flow to the brain, you increase it a little bit to the heart, but in return, you're going to reduce blood flow to things that you don't necessarily need a lot of during exercise, like the liver and the kidneys. And then shifting gears a little bit so we were just talking about aerobic exercise, moving into resistance training or weightlifting. Big thing here, if you're talking about dynamic weightlifting, like doing a bench press where you're actually moving the bar, or doing squats where you're moving up and down, the physiological response mainly depends on two things: how hard you're working, so the intensity, that's how much weight you're going to be moving, and then the number of repetitions. So if we look at something like heart rate, it goes up during weightlifting, and it's going to go up higher if you're lifting more weight, which makes sense. So the harder you're working, the higher your heart rate is going to go. The more weight you lift, the higher the heart rate. Same with the number of repetitions. If you do 5 repetitions versus 20 repetitions, the heart rate's just going to keep going up. So the more repetitions, the higher the heart rate. Stroke volume, a little bit different here. This is where we see a difference between aerobic. So instead of going up during resistance training, stroke volume either stays the same or it might decrease a little bit. So you don't get that big increase in stroke volume that you get during aerobic exercise. Cardiac output, since it's a product of heart rate and stroke volume, is still going to go up, just not as high as it did during aerobic because stroke volume is not going up. Systolic blood pressure, diastolic blood pressure, both of them go up during resistance training. And this is why I put this slide here, or this picture, where this is systolic, this is diastolic. So you can see each one of these dots represents a repetition. So the concentric and eccentric phase of an exercise, this is like just basic leg extension exercise, but you can see during the concentric phase where there's a lot of effort exerted, blood pressure goes up, and then during the eccentric, when you're lowering the weight, it goes down a little bit. And then next repetition, up, and then when you lower it, down. So blood pressure just keeps doing that. The interesting thing though is the more repetitions you do, it just keeps climbing. So blood pressure goes up, systolic blood pressure in this case is going up, and as you do more repetitions, it goes up even more. And then you can see here they rested and then did a second set. And you can see as you continue to do more and more sets, the blood pressure tends to keep getting higher and higher. Diastolic blood pressure, exact same response. So the reason that you're getting the increase in diastolic blood pressure, where we did not see that during aerobic exercise, is because you don't get that dramatic vasodilation that you got during aerobic exercise. So TPR, total peripheral resistance, still goes down a little bit, but it's not near as much as what goes on during aerobic exercise, and thus that's going to force diastolic blood pressure to go up.